ultrasound over that. Put it all together into a diagnosis management plan, and then take it from there.
Don't need interruption of the CPR. If you do focus, will it not interrupt the your continuation of CPR and
So I
quality
think
CPR? Will it hinder the quality CPR
no,
when you do focus?
I think that's one of those things that everyone is worried about, interruption of CPR when people are trying to do POCUS scans. First and foremost, basic CPR must be the number one thing that continues. However, as people get more and more skilled with it, I think point of care ultrasound does add a layer of information that's very useful. I'll give you an example.
Yeah.
So, for example, we know that some cardiac arrest calls are caused by pulmonary embolus,
Yeah.
and more often than not, it's a diagnosis of exclusion. You work down, all the decision trees, and you think, okay, I've got nothing left, therefore, it is pulmonary embolism. But with point of care ultrasound, a simple subcostal view, you may see, a dilated RV, an impaired RV, and in the right circumstances, that pushes you more towards PE. Another example is if you look at cardiac tamponade. Before, it was a diagnosis of exclusion, and then once you work down the four H's and four T's, if nothing left, tamponade. But with ultrasound, you can see it directly, visualize it directly.
Nice answer, nice answer. I think we should, the expert of focus should be there whenever there is a CPR, prep more in the young patient, salvageable patient, we should emphasize.
Agreed. And I think, but with like most things in POCUS, especially in cardiac arrest, it's a team approach. You've got someone doing the chest compression, someone managing the airway, and then a trained person doing the point of care ultrasound. Unfortunately, if you look at the international guidelines on the Resuscitation Council and whatnot, the point of care ultrasound use is only a recommendation provided there is skilled people available to do it.
Okay, another question, do you think the venous access ultrasound VEXAS can better predict fluid responsiveness over simple IVC diameter or collapsibility measurement?
That's a very interesting question. And first and foremost, I think I've been following the VEXA story very closely now, and I think it has its utility. Do I think it will predict fluid responsiveness better than the IVC itself? I think it's probably better than the IVC itself. But does it predict fluid responsiveness? I'm not sure. In my practice, what I tend to do is to use VEXAS as a marker of venous congestion and fluid tolerance rather than fluid responsiveness per se. Now, obviously, those two principles of fluid responsiveness and fluid tolerance, there is a degree of overlap between them. But in my mind, I sort of separate the two.
So there can be some errors when you are doing a simple IVC collapsibility, especially in patients who are breathing spontaneously and very fast. They are gasping, and patients who are on NIV where there is combination of positive and negative pressure swings,
Absolutely.
and also where there is respiratory efforts over a ventilator and other condition like RV dysfunction, COPD, severe COPD, where there is right ventricle failure. So these are the situations where it can be false positive or negative.
Agreed.
So how you negotiate such
So I
situations
never.
in these cases?
You're absolutely right. All the situations that you mentioned limit the utility of IVC in terms of fluid responsiveness. I do, in my practice, I would never, 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 never look at the IVC by itself. I think when you look at the IVC, you need to look at it in a combination with knowing what the respiratory parameters are, so positive pressure or spontaneous breathing, and genuinely what the RV, LV are doing. You're already there. Just look at the heart. Do not rely just on the IVC.
Yeah, that's a very valid point. Another question I would like to ask, whenever you diagnose pericardial effusion and tamponade in an unstable patient and you think that it is causing the collapse of a patient, so will you do pericardiocentesis directly, or there can be a false positive pericardial tamponade and it can lead to adherent possibility of cardiac chamber perforations, and how can you avoid such situations
Okay,
in
so
the
I think that
acute settings?
every patient is different. So if I was convinced that this patient's collapse was due to pericardial effusion leading to tamponade physiology, you would see it on ultrasound. You would see an RA that's been collapsed down, your RV that's collapsed down. And in those situations, provided the patient is salvageable, we would perform pericardial synthesis. I think a pericardial synthesis these days should be done under ultrasound guidance, especially since you have an ultrasound machine there to make the diagnosis in the first place. I think when it comes to reducing the risk of puncturing, damaging the various cardiac chambers, I think the top tip I would give to you is the same tip I would advise for any invasive procedure guided by ultrasound, which is you need to visualize the needle tip. And I would always advocate real-time needle visualization rather than ultrasound markings that some
Sometimes
colleagues.
you may be confused by the epicardial fat, or even there is a collapsibility of the IVC. If it is more than 50%, should you look at the IVC collapsibility also when you are?
I think you do, but with if your the clinical picture takes needs to be carefully assessed. So if you've got pampanat physiology, you've got an RA/RV that's collapsed down, you've got an IVC that's dilated and non-collapsing as well. That's tamponade physiology. Now, if you one of the points you've raised is whether you would mistake a pericardial effusion with a fat pad. Now, I think in those situations, we need to be very, very clear in our own mind as healthcare professionals. Do we know what we're doing? If you are not sure, then you err on the side of caution. Never practice outside your realms of competency. Never practice outside of what you've been trained to do.
Yeah, thank you, thank you. Next question I will ask to what are the clinical echo findings of a acute pulmonary embolism, which is massive and which is you want to thrombolize in a acute condition, in like in emergency when
Mhm.
you suspect this is PE. Can you thrombolize such patients in the emergency
Well, I have
based on the POCUS findings?
I think I would never again rely on just the POCUS findings. So I just reflect back to the case we've recently had in my particular hospital. There was the right clinical history, so someone who was short of breath. You had the appropriate clinical examination. The chest itself was reasonably clear on auscultation. And then when we looked at the heart, we had a dilated RV, which wasn't which was impaired as well. Systolic function was impaired. So in those situations, provided the circumstances were right, we decided to thrombolize this patient. Now, to answer the second part of your question, which is sort of how do you tell whether this is acute or not acute? The difference obviously is that in the chronic setting, your right ventricle has had time to adapt. It's adjusted to the fact that you've had chronic pulmonary hypertension for a long while. So things that you'll be looking for. What is the wall of the RV thickness? Is it like in the more chronic situations, you would expect it to be thicker?
Yeah.
In terms of the septum, what does the pressure chambers look like? So in the more acute setting, generally speaking, the right ventricular pressure exceeds the left ventricular pressure in the systolic phase of the cardiac cycle. If it's more chronic, generally speaking, you get it both in the diastolic and systolic phase. But the thing that I probably use most often trying to work out whether this is acute or chronic problems is to look at the thickness of the right ventricle.
And also, we have recently thrombolized one patient.
Mm-hmm.
A patient had a young patient, female, who had a cardiac arrest in the emergency when she had a D-shaped this echo focus finding on the
Yep.
ventricle.
Did she do well?
D-shaped. No, she did not survive.
Sorry.
And what I feel we thrombolize, but sometimes still patient is so sick even after thrombolysis, and I have thrombolized on the basis of suspect only.
I think before the days of echocardiography, we would rely more on clinical history, clinical examination, and we take that risk and thrombolize.
Very good. Thank you. Thank you. And next question, my final question. When can we have false lung point on the focus? And what are the definitive signs of pneumothorax on
Okay.
focus?
Okay. So just to explain to colleagues who may not understand those terminologies, when we talk about lung ultrasound, one of the first signs we look for is lung sliding. And lung sliding is essentially the movement of parietal and visceral pleura moving against each other with respiration. it is very, very important to realize that every single bit of that definition needs to apply. So, for example, if you've got a patient who's previously had a pleurodesis, for example, you will not get sliding because parietal and visceral pleura have been stuck against each other, and so they're not moving against each other. In the case of a pneumothorax, parietal and visceral pleura are separated. That's the pathophysiology of a pneumothorax. And so you will not see lung sliding. The lung point is that interface between a lung that's inflated against the chest wall versus the pneumothorax. That is 100% sensitive for a pneumothorax. Now, there are caveats to this, and as mentioned, one of these is where you have your pericardium fold, so your normal heart, being against the pleural flow. That usually happens in the obviously on the left-hand side, usually around the nipple line. Again, there are certain things that you can do to differentiate it. One, lung pulse, false lung point because of cardiac pulsation is in the region of the heart. You will not see it on the right-hand side. The other thing that you can do if you are not sure is to use M mode on it. And with M mode, you can differentiate between the seashore sign and stratosphere sign. But more importantly, on the M mode, you might see something called the lung pulse, which is the cardiac pulsations being transmitted through the lung and onto the ultrasound probe. If you've got a true pneumothorax, you will not see the lung pulse.
So I would like to ask if there is a lung is expanding and then there is a heart, or lung is expanded and so there is a lung sliding sign and then there is a diaphragm. So on that interface you can have
Absolutely,
false lung point.
absolutely. So this is one of the points of point of care ultrasound is that it needs to be, you need to be trained to do it. You need to know your anatomy. It's not a substitute for knowing your anatomy. So if you see what you think is a false lung point in the diaphragm, diaphragmatic area, think about the diaphragm.
Okay. Thank you so much, Adrian.
No problems. Thank you very much for having me.
Nice answers. I'm really impressed with you. Thank you. ठीक है ना?
Short and sweet.
Good.
Thank you very much.
लेना एक फोटो एडियन और मेरा ले लेना एक
Okay.
चश्मे में